We had an excellent kickoff to this conference. My name is Christina Bizans. I'm the CEO of CHATS, Community and Home Assistance to Seniors. I'm also the co-chair of the Ontario Health Central CSS Advisory Table. We had an opportunity to hear from Matt Anderson and Susan Direct this morning in the kickoff plenary about the changes and transformation that have taken place in our health system, the path forward, the health plan that Matt outlined for us. And of course, the question on all of our minds in our particular sector is, what does all of this mean to us as a sector and as health service providers? How do we move forward along with the very ambitious plan and ensure that we are adding value not only to the health system, but continuing to add value and demonstrate that value to the clients and people that we serve? So to start us to think about some of these questions and to start to enable us to take more of a leadership role in the opportunities that are presented to us, we have Dan Carbin, who is the managing partner of Santis. Dan co-founded Santis in 2012 after serving in a variety of senior advisory roles in the Ontario government. During his time at Queen's Park, Dan served as a senior advisor to the Premier, Deputy Premier, and 2 Ministers of Health. Dan helped drive forward some of the government's signature healthcare initiatives, including the wait time strategy, the creation of local health integration networks, primary care reform, and physician services negotiations. Dan also worked as a parliamentary researcher in the UK for a member of Parliament and health critic. At Santis, Dan provides strategic advice to boards and executives in the Canadian healthcare sector. His clients include leading national and provincial healthcare associations, broader public sector organizations, and a range of health charities. Dan is the past chair of the board at St. Jude Community Homes, which is a provider of supportive housing for people living with mental illness. He's also served on several corporate advisory boards and holds an MSc with distinction from the London School of Economics and a BA honors from McGill University. Dan lives in Toronto with his wife and 4 very active daughters. So Dan, I'll now turn it over to you. We look forward to your comments.
Thanks for that, Christina. And Eleni, if we could go to the next slide, please. Just for context, I think Christina went through my bio. I think for the purposes of this conversation and why I'm here speaking after the folks from Ontario Health and what in baseball, I guess you'd refer to as a murderer's row of presenters, a really high quality list of people talking about what's happening in transformation in the Ontario health system and what it means for the CSS sector. I think the perspective that I bring is that I have been in government. I know how government works. I know how people in government think. I know what the strategic considerations driving decision-making, resource allocation. I work with government a lot, the broader public sector, both federally and provincially, but I'm not in government. And that allows me to be a little bit more open in sharing my actual thoughts, and perspective and advice with clients. A lot of people, when they leave government, feel like they're not, there's a little bit of a loss. I actually felt incredibly liberated that I was able to talk with organizations in the healthcare sector, offering as objective advice as I could, not coming at it from the perspective of serving the interests of government. So I'm hoping to share that today. I'm not going to be talking in specific detail about what's happening in the transformation agenda with the Your Health Plan, with Ontario Health, with the creation of Ontario Health Teams. You've got others that are going to speak to that. But what I'm going to try and talk about is really what's happening at a meta level, both in the health system and in society, and how the CSS sector over the medium to long term can strategically be positioned to most offer help to advance these societal and public sector, public policy challenges. So if we go to the next slide, please. This is a quote that I'm sure many of you have heard, that it's been attributed to Bill Gates about 30 years ago. You know, the people coming out of COVID, you know, looking at this from early 2020 might not agree with this sentiment, but it generally rings true that when you're planning as an organization, you really focus on all the change that's right in front of you, and you overestimate what's going to change in that 1 to 2 year period. And you really underestimate the change that's going to occur over the longer term in the next 10-year period. Profound societal change will take place over the next decade. And it's really important for senior leaders and boards to be thinking about those long-term shifts to position your organization for success. So don't be lulled into inaction by the seeming lack of change in the short term that doesn't meet your expectation for change, because that it is inevitable that profound change is going to happen within the next decade. Next slide, please. You folks live and breathe this every day. You see the reports about the changing demographics in our society. You see it on the front lines in terms of the population you serve. But it's still, you know, every time these reports come out, it's staggering to me when I look at the details to understand just the profound nature of the change we're going through. It's obscured sometimes in Ontario, you know, in York region, where many of you operate, by significant levels of immigration. But even with all of these new, young people coming into the country, we still are undergoing what is recognized as a transition to a super aged society, a rapid aging of the population. By 2041, over a quarter of the population in the 65 plus category, 80% of those new seniors over the age of 75. And I don't know if folks saw the articles in the Globe last week by an actuary talking about your odds of living to 90 without profound illness. I don't want to put a damper on people's day, but it's not good. Most people that are living into their 90s are struggling with a variety of profound illnesses and need some kind of support from society in order to live well in their later years. And we're simply going to have a lot more people in this older age category to deal with. The fastest growing cohort, as the people at this conference know, is the 85 plus category, growing by over 6% a year in this period before 2041. So over the next 2 decades, profound shifts that might not be noticeable on a year-to-year basis, but really start to kind of overwhelm our system if we don't do things differently. And it happens slowly at first and then very, very quickly. On the next slide, please. We have, in the past number of years in the province, the focus on addressing, what was uncharitably in the past called a tsunami of aging, has been to focus on building out long-term care capacity. So the government now talks about its commitment to build 30,000 new long-term care beds by 2028, which they refer to in their press releases as the largest long-term care build-out in Canadian history. It is a significant build of long-term care when you consider that when this government came to office, there were somewhere around 78,000 long-term care beds. So they're adding about 40% of the existing bed stock in new beds into the system. But despite that historic, massive, unprecedented build-out, when you look at what this actually means to our populations, our ability to serve the elderly population through long-term care, we're essentially we're spending all this money, we're building all these homes, we're acting furiously to stand still in the current position. So the Financial Accountability Office of Ontario ran projections through just after this build out of 2028 to get to 2030. And really the number of long-term care beds per capita continues to decline through this period because of that significant growth in the very elderly within the population. So there's a brief bump or brief lull as some of these beds come online in 25, 26. But then towards the end of it, we get back, we're really worse off than we are today. And I think it's worth keeping in mind that the government's response in long-term care was driven by the fact that wait times, that the wait list for long-term care doubled between 2010 and 2020. So this is in a way, the best case scenario. If all of these beds get built, we maintain a wait list of around 40,000 over the next decade. Wait times are still significantly elevated over where they were previously. And this is with a Herculean effort to build out the long-term care system to essentially maintain access to care that we've got today in a best case scenario. Next slide. And of course, this isn't coming cheaply. Long-term care capital expenditure, in particular, there's two major components driving the increase in long-term care. The necessary investment in operational expenses that the pandemic made clear, the investment in new staff and additional levels of service for an increasingly frail population, but also the significant build out of new long-term care capacity. What's really interesting in this, when you look at this chart, so this is long-term care spend growth from the Financial Accountability Office, projecting 9.3% annual growth on the decade between 2019 and 2029. And they note that at the budget projections at the time, this long-term care spend would require essentially 33% or 1/3 of all new health sector spending to fund this kind of build out in long-term care. So this is a significant component of overall health system expenditure in Ontario to kind of keep today's level of access to long-term care. Next slide. People would have probably seen that there's been a lot of challenge in actually inducing developers to build these new beds. So when I was in government, I think the subsidy for long-term care, the daily subsidy, was something like $16. That's been increased in a base rate to over $20, and there's all kinds of top-ups for smaller homes associated with it. The government also recently announced a new top-up for homes that's a time-limited top-up to really incentivize a lot of developers to get into the market of $35. So they provided an incentive that is over 100% of what the actual the rate has been. There's also a development grant in there. When you add all these up, it means that the government will be flowing between $550,000 and $600,000 per new long-term care bed. Now that cash flow is not discounted because they pay the same amount every year, essentially for 25 years. So you'd have to adjust it for inflation. And I'm sure people with better financial chops than me could do that very quickly. But in terms of the cash flow going out, it amounts between $550,000 and $600,000 per new long-term care bed. So the question is long-term care the only solution? If you're going to be investing, when the long-term care is necessary, new long-term care is necessary. There's a clear wait list. There's lack of supply for the people who need it. But the question is, when you're looking at incremental resources beyond this 30,000, and you're looking at a build out of $550,000 just for the build of a new bed, plus the operational costs, are there some other ways that we could think about directing that new money that is going to need to be invested in the system? If you go to the next slide, I mean, this slide was this information is kind of shocking to me, and I apologize that the font is small, but in the OECD, Canada spends around the average in the OECD on seniors care issues, what they define as long-term care. But that includes home care and community support services and social care services. So it's a very expansive definition of long-term care. Canada is around 2% of GDP. A lot of the Nordic countries are around 3.5% of GDP, so almost double, even though some of them have lower overall health spending as a percentage of GDP, which you can draw your own conclusions, if you will, there. But in Canada, that 2% is allocated almost entirely to institutional care. 82% of it by the OECD's calculation goes to institutional care. And I'll note that not all of that is long-term care. Canada has one of the highest shares in the world of what the OECD defines as long-term care spent in hospitals. So a significant, what you might refer to as a misalignment of resource to care for the needs of an aging population in hospital and in institutional care more broadly, compared to a lot of the countries that folks in this room would have studied as more models of aging. You see Denmark way down there at the bottom with the vast majority of its expenditure in community-based services rather than institutional care. So long-term care is part of the solution everywhere. And institutional care is part of the solution everywhere. The question in Canada and in Ontario is, why is community-based care not more part of the solution? And how do we make it a more balanced system as we go forward? Next slide. It's not like this issue isn't studied a lot, or that people aren't thinking about this. There's been endless reports. I mean, I remember when I was in government, there were some suggestions, reports that as many as 1 in 4 people in long-term care could have been cared for in the community. The Kai-Hai report from, I think, just before the pandemic said, looking in 2019, of the people that were admitted in 2019, and these are people that are much more frail, with much more higher levels of complexity than people a decade ago, even 1 in 9 of those individuals admitted, in their view, could have been cared for at home with enhanced supports. And the question is, why wouldn't we do everything we could to meet the needs of people at home and in the community where they want to receive care and where it's more cost effective, before defaulting to long-term care? Next slide. So I've asked myself this quite a lot through the years. Like, why do we default to long-term care? Why is it that becomes a solution? It is a solution. It's a part of the solution. We need lot more long-term care, as I've said, but why has it become the default solution from an investment perspective? And I think there are a few things to note that I'll go through. The first is that it's easy to make a public story about wait lists and wait times for long-term care. They get media attention. Governments respond to media attention. There's pressure from the acute sector. Get this person out of my hospital. They need to go in long-term care. There's no long-term care. It's an easy story to tell the government. There's that story told by the hospital sector is often couched within the financial rationale. Look, it's going to cost you $1,000 a day to keep this person in a hospital bed. There's a better use of that bed. You can put them in long-term care for $200. Long-term care is also, compared to home care in the community support sector, a kind of known commodity in that it's heavily regulated. There's a consistent flow of funding. There's a consistent, in a way, basket and level of service that's micromanaged down to the amount that's allocated for food and everything else. It's a system that government knows how to manage. And there's a perceived lack of alternatives for the frail needs and elderly. I think there's a lack of real faith within policymaking circles that investment in home care and community support services doesn't really kind of disappear into the ether and get spread thin. That whether that's fair or not, that an investment in long-term care to open up a bed that Mrs. Jones is going to be in the long-term care bed, and you can see that Mrs. Jones is in the long-term care bed, whether that's an appropriate measure of support or a success or not is open to question. It's certainly not a societal level of success. The final thing to note that I saw a lot in government is that members of provincial parliament and governments as a whole love tangible things. They love being able to cut ribbons. They love being able to have announcements and put shovels in the ground and news in the local papers, and new long-term care bills kind of satisfy that and offer that. So there's a lot kind of in the incentive structure that favors this investment in long-term care. Next slide, please. Then the questions so again, thinking, well, the case for more investment in community-based services and community support services is so clear. Why, there have been investments in community support services and home care services, but not nearly at the level that we would all hope, not nearly at the level that you've seen in that long-term care build out. Why is that? And how do we change that? I think that there's a few things to note here. There's still incredibly poor understanding of the roles and functions of community support services by policymakers, especially, people moving into the bureaucracy from new ministries, new roles, into political decision-making. They don't understand a lot of the time the difference between home care and community support services. They don't understand why services are offered in one region and not another. They don't understand why there's not a consistent kind of basket of services. They don't understand, in some cases, Why are these services paid for by the government? Why are they paid for by the individual in some cases? Why is there no coherence around what the public pays for? In long-term care, for better or worse, we know what the public pays for. In hospitals, we know what the public pays for. There isn't that coherence in the home and broader community support sector. There's also a sense that there's significant fragmentation, and this goes back decades, that governments, if given their druthers, they would consolidate the community support sector. They would reduce the number of agencies by 90%. It would make their lives, in their view, easier. There's been no desire to take the political hit for doing that. So instead, there's been a kind of carrot and stick approach through constrained funding, promotion of incentives for integration to try and address what is seen as a significant fragmentation within the system. That fragmentation, the lack of understanding of the basket of services leads to a belief that there's not really an investable model that you can scale across the province. You know, when you're going to put long-term care out or hospital beds, there's a kind of framework, there's blueprints, there's a sketch for that. It's in community support services, there's not a clear leading model of say long-term care at home that has been tested, that has been scaled, that there's enough evidence and literature and faith behind that it will be that you could invest in it and scale it across the province. And that's tied to the fact that there's fewer clear performance metrics in the community support sector. Next slide. So that wasn't intended to be depressing. I think that it was intended to be a bit of a reality check, which is there's a lot of work that needs to be done. We all know that this is what needs, that the future of aging care in this province, whether it's 5 years from now, 10 years from now, or 20 years from now, is going to hinge on the success of an integrated community model. Getting there is going to require lots and lots and lots of work. But we can never give up on the fact that we will prevail. We will get there in the end because it is the only solution that really makes sense, and it's what people want. So it will not be a straight path, but there's lots of optimism that we will get there in the end because it is what this society expects and needs as it ages. So on the last slide here, I have a few kind of strategic thoughts for executives, if we flip to the next slide, about what can be done from a strategic perspective in addressing this. These are not concrete recommendations around, addressing your health human resources shortage or dealing with your MSAWs or dealing with Ontario health teams, but just how you should be thinking about some of these challenges. The first is all organizations and the association, and I know OCSA is speaking later on this, really need to continue to focus on educating about what you do, the value of your programs, the service offerings, and the impact of those services. It's really, really important where you can, and I know evaluation is often not funded in the work that you do, but to find research partnerships, to find other ways as part of, if you're part of integrated teams, to be able to show that the involvement of CSS agencies in work makes it not only a qualitative difference, but a quantitative difference that you can track and measure and show the impact of. I talked about the impetus and the pressures around integration and consolidation previously. It's been pretty clear for, I'd say, several decades now that organizations that simply rely on base funding are consigned really to decline as organizations and to struggle to offer services to their clients. There's a lot of funding through initiatives, through partnership-based programs, through other funding streams, and relying on base funding is really a struggle for organizations. And that really requires organizations to think about a partnership-based strategy for smaller organizations, to have board conversations, executive conversations around what are the principles, the values around partnership, when would they consider potential integrations or mergers, and under what circumstances, what does it mean for, what would they need for their clients, for their staff, for the organization to make those kinds of partnerships and or integrations or mergers work. And this needs to be considered both within the CSS sector, but also how do you build other broader partnerships? And I think especially in the future with primary care and primary care networks as they start to emerge more strongly. The final recommendation here is that, you know, we're in a period where there's disproportionate focus on firefighting. The government doesn't like to refer to it as crisis. You can all refer to it as crisis because that's essentially how they're responding to the situation, which is throw money and energy at the issue that presents itself right in front of you, whether that's ER wait times, ALC, surgical backlogs. All of these things are important, but we can't only be in a crisis mode forever. So I think it's important for CSS agencies to be part of responding to crisis solutions, part of ED, ALC work and solutions, getting people transitioning from hospital to home. But it's not just important to be part of them for being part of resolving the crisis. It's important to be able to be there to educate others in the system about what you do, the value you do, and to be able to spur the conversation about, okay, we're dealing with the crisis now, but how about we focus on, you know, preventing this from happening in the first place, providing a broader basket of community-based services to keep people well once they transition home, or to stop them from coming to the hospital in the first place. So using your role to really spur those conversations and advocate for a refocus. I've been asked to keep my comments to stop at 10:20 to allow time for questions. So I'm going to wrap up there and take the slides down. And I think Christina is going to triage some questions.
Dan, thank you so much for that that presentation, and you know, some very compelling numbers. I think that definitely show there is a crisis, but also the immense opportunity that exists too. That slide that you showed, Canada relative to other countries in terms of the amount that we spend at a time when there is such a focus on looking at ways of being more efficient and effective, and allowing people the dignity of having a choice of how and where they want to age. Recognizing that with increased age, there comes increased frailty. We did have a question about the name of the report that on long-term care that you mentioned. So perhaps we can post that in the questions.
Sure.
Some of the questions sort of / comments that we received included, boomers like me don't want institutional choices, but want community-based care in a home-like setting. Why can we not invest in natural housing communities as opposed to institutions, care villages, for example?
Why can't we? I don't know. I think it goes back to I don't want to call it laziness, but it is easy to invest in the things that you already have a model to invest in. So invest in a long-term care model. Yeah, you have to increase the amount that you pay in the per diem, but they haven't fundamentally changed the investment model or how that system is structured. I think there does need to be overall, from an aging policy perspective, a bit of a reset where we say, okay, how do we look at how we provide alternatives? Where this long-term care build is going to happen. There's going to be these new homes that are built. But when you get to 2028, how are we not stuck in the same conversation so that the default that a political party is running on its platform is to build another 30,000 of the same kind of beds? You know, how do we build, how do we invest in community-based housing solutions and support that? There are tons of models out there. We need to really catalyze the conversation around some of them, and it does need to come through the political process in advance of in advance of elections. Really, that's when a lot of these commitments kind of get baked in.
Thank you. Another question was, why not consider incentivizing family members to help their senior parents at home with some support from, say, PSW's attendance as required? This would save money and be better for the senior.
Yeah, I think there has been some, I mean, there's been movement at the federal level, I think, where they've introduced caregiver tax credits. There's been some movement there at the provincial level. There's been some experimentation with self-directed care models in very limited ways, including, policy discussions around whether caregivers could be brought in, at like informal caregivers in a paid capacity to support that. I don't want this to sound, I'm trying to think how to say this. The risk, the fear in government and policymaking is that our system in some respects is reliant on informal and unpaid caregivers to fill in the gaps. How do you draw the line? Like when we need, from the perspective of the Ministry of Health and others, we need those people to continue providing unpaid caregiving. How do you not transition them into a totally paid workforce and destroy the voluntary nature of unpaid caregiving? How do you maintain and support unpaid caregivers? So I think without stopping their work as unpaid caregivers, and how do you, as the public, I think as the government, not assume the financial liabilities for all the work they do? So that is the very, in a way, that the gritty policymaking consideration there, which is why there's been more interest, I think, in investing in things like respite programs, which allow caregivers to keep doing what they're doing in an unpaid way. I don't know whether the health human resources crisis will force people to think about this differently, to say, hey, how do we get these people that might be doing a few hours a week, how do we give them the capacity to do more? Because there simply aren't enough paid caregivers that we can find to do the work. So maybe that changes the dynamic.
Thank you. Another question is, can you please comment on 4-year cycles impacting on planning over the longer term?
Yeah, I touched on it a little bit with the election cycle. They're incredibly important. When I was in government, there was a push by the ministry to create a 10-year strategic plan for the health system. The political arm of government, which I was a part of, would not allow that to happen, because it's very elected governments do not want to make commitments that are beyond that they feel accountable for, that are beyond the term of government. So effectively, the planning cycle is 4 years. The budget cycle is 3 years and generally fits within that, but a new government, if they're elected, can re-baseline the budget. So really, we are thinking mostly about 4-year planning cycles. Capital expenditure is kind of different, because you make a commitment now, whether it's a long-term care build or a hospital build, you're going to be paying for it for 20 or 25 years. So you kind of lock those decisions in and tie the hands of a future government beyond that 4-year cycle.
Thank you. We need to keep a strategic focus on maintaining and supporting the transition of leadership that we are currently experiencing to ensure sustainability in our advocacy efforts that many of us have been involved in for many decades now. Your thoughts, Dan?
No, I feel like you folks are probably better positioned to answer that one in terms of, the people well that are coming up through the ranks. There's a tremendous turnover in leadership. What I would say, though, is that there's also tremendous opportunities for younger people now to exert leadership roles within organizations that might not have existed before if you had a single funding envelope. If you're participating in 3 or 4 Ontario Health teams, that's a great opportunity for your younger staff to be able to manage these very complex relationships, negotiating dynamics that involve hospitals, that involve primary care, that involve home care organizations. So what a fantastic opportunity for people to be able to see actually how the system works and how the system operates and how those challenges of transitions really impact care. And that should be seen as a training opportunity to identify, to give people the kind of system view they need to be able to take on those advocacy roles.
Good point. Another comment. We have hired a primary care physician as an integral part of an integrated interdisciplinary team to operate a PACE-like clinical model for elderly ADS clients with dementia. Ontario Health funders just told us we can't do that. CSS providers know what we have to do to support a paradigm shift from downstream to upstream investments to support aging in place. We need to hear yes versus no when we are trying innovation.
Yeah, there is this paradox when you're told you need to innovate, you need to bring ideas forward, but then no, the rules don't allow you to do that. And I would say that there are, one of the slides I had talked about partnership. There is, I know certain CSS, I remember, I can't remember which agency merged with a CHC. I know I'm working with a couple of CHCs at the moment where the work they do really converges on the work and that a number of CSS agencies do. So I wonder if there are, in communities where there are community health centers, using them as the vehicle to apply. The government can spend on community health center physician services, can spend net new there. So if there are ways of structuring partnerships to get around some of these bureaucratic impediments, because changing it head on, it can be done, but it will require a tremendous amount of time, effort, and energy.
Yeah, thank you. A couple of other questions, but we are down to 1 minute left in this session. So I am going to leave off with the last question, which I think is the essence of what we've talked about today. Dan talked about educating the government on what we do. What is the best way to do so?
Well, I know Patrick from OCSA is speaking later, and I'm sure can address that even better than I can talk about the work the association's doing on your behalf. The best thing I found in government is you can see a slide deck, you can read a briefing note, you can read a report. The best thing is to see it in person. So inviting members of provincial parliament, inviting political staff to come and see what an adult day program does, to see what supportive housing does, to see what a home visit looks like. That opened my eyes and changed my mindset completely. And I wish I'd done that at my first month on the job, not like 3 years in.
Thank you so much, Dan, for being here with us this morning, for your comments, your insight, and just your recommendations on how we can really take on more leadership roles and communicating not only what it is we do, but why it's important and the value of it from a systems approach. So we really appreciate your time here. Thank you so much. And thank you again, Dan, for being with us today.